Welcome to the channel, everyone. My name is Nick Christelis. Today we're diving into the topic which is often misunderstood, often misdiagnosed, and even dismissed. It's complex regional pain syndrome. If you're watching this, you've either got it or somebody you know has got it, or you are interested in this topic. CRPS is complex, it's debilitating, it affects the central nervous system, the peripheral nervous system, and it basically can destroy a person's life and, of course, that person's life around them. Despite how serious this problem is, there are still many myths around this problem. So today I'm going to introduce Dr. Bradley Lewinsohn in a second, and he is a leading pain specialist in Melbourne. I'd like to talk to him about unpacking some of these myths about CRPS. I'll let Bradley introduce himself. Before we get started, Bradley, just tell us a little bit about yourself.
My name is Dr. Bradley Lewinsohn. As Nick has said, pain specialist in Melbourne, and I'm very glad to be here today to be able to speak to you, Nick, and the audience members about this topic because it seems to have a lot of mysteries still surrounding it, especially when patients come into the clinic. They've been suffering with this condition for a while. No one's really sat down and explained the condition to them. And it's always useful to reach out to patients, give them a little bit of information about how we can manage this to a certain degree. And so I'm really glad to be here today to be talking about this because it's something that I see quite often in my clinic.
So before we get into the myths, these 5 myths that you and I commonly see in our practice, briefly explain to me what CRPS and how it's a little different from some of the other chronic pain conditions that we see and treat.
CRPS will fall into the nerve pain conditions. So in pain medicine, we like to try and categorize pains. So we have neuropathic pain, which is pain primarily resulting from the nervous system. And then we have nociceptive pain, and that would be similar to patients who are suffering with osteoarthritis or joint pains or pains from other musculoskeletal tissues. And then there's obviously pains that cross over, and we'll call them a mixed pain picture. And CRPS would fall into the neuropathic pain conditions. And there's a whole wide host of neuropathic pain conditions, including patients who are suffering with neuropathic pain due to damage from an infection, such as shingles would be an example of. Diabetic patients can have damage to the nervous system because of high sugars in their blood, which would give them a nerve pain or burning in the hands and feet, and we call that peripheral diabetic neuropathy. And CRPS is another type of nerve pain, but it has a completely different pathogenesis, i.e., way that it starts up, and that would be due to an injury that a patient suffers. An injury could be anything from a simple sprain or a post-surgical injury where you've undergone surgery to a certain degree, or a direct injury to a nerve. What usually happens is that when you have these injuries, you have some pain afterwards. The pain generally starts off bad and then resolves within around a 3-month window, depending on the extent of the injury. However, in chronic regional pain syndrome, for some unknown reason, instead of the body going into this healing phase, the pain persists and winds up, and you end up developing this condition which goes beyond the 3-month mark of what we consider normal healing.
I've always thought of it as a pain processing problem, an autoimmune problem, and an autonomic problem. So I suppose you say to a patient, it's a pain condition that I can see, or it's a pain condition that you can see. In your experience, how does CRPS typically show up in your clinic? Do you see it early? Do you see it late? Tell me a little bit about the patients that you see.
Well, I have some patients that come into the clinic early, and you're right. When patients come in early, it's easy for us as clinicians to make that spot diagnosis. Early on in the disease, you have all these typical signs and symptoms. The affected limb can be red, it can be swollen, it's got tenderness to touch, and there's a temperature difference between one side and the other. And as soon as you see all of these signs and symptoms together in a patient, you can easily make the diagnosis. Unfortunately, a lot of patients I see much later on in the disease, and that can be for various reasons. For instance, a patient's had an injury to a limb, has gone into the emergency department, they've immobilized it either in a boot and a cast, and so the pain keeps going despite the patient having the limb immobilized. And in fact, they go back and sometimes have a cast change or change the moon boot, and no one actually gets to see the limb, and so it doesn't actually see the underlying initial signs and symptoms. And they can present much later on in the condition procedure pathway. And it can be a bit more difficult to spot these patients because some of these classical symptoms and signs that you get with the discoordination of the nervous system, the changes within the limb temperature, color, swelling can dampen down over time and can present as a slightly different picture, which makes it even tricky for other non-pain specialists to pick up in the community.
Okay. Well, let's dive into the first myth. CRPS is in your head. This is something that we hear patients tell us about almost all the time. This is not real. This is a problem with your head. This pain is in your head. Tell us a little bit about this. Why do you think we have this myth of pain or CRPS that's in your head? And you've mentioned a little bit about the biology of CRPS. So tell us a little bit more about that.
So I think that's a common misconception because if you think about it, ultimately, all of a human experiences are in our head. That's where we experience sight. That's where we experience sound. It's where we experience taste, soft sensations in the body we experience. It's all coming in the brain. And the brain is the central processing unit to a large degree. Where pain gets experienced, it tends to start off in the peripheries, where you have pain fibers. They go into the skin, and then it travels up through the spinal cord and then gets rerouted through the brain through some deep brain structures where all of a sudden we then start to experience the sensation of pain. So in one extent, pain is all in our head. On the other extent, however, the patient's not malingering and making up this pain. They're not imagining this pain. This is a real pain. And it's something that we sometimes have to deal with in our clinic where patients come through and are self-doubting themselves because pain is supposed to be part of the natural signaling pathway, Nick. It's part of keeping us alive, stopping us doing silly things. People who don't have pain have a shorter life expectancy. There are some people born without any pain receptors. A very, very small percentage of patients have this pathological no pain state and their life expectancy goes down. So pain is a vital part of being alive. But what happens as you were saying earlier, with these discoordinations, the pain takes on its own life and then becomes a pathological pain, a pain of no biological function. And it's something that we have to try and adapt to and modulate to make sure that patients can still function despite having this ongoing pain. So I think the myth is a bit of a misunderstanding with regards to patients that it's in their head to a certain degree.
So you experience pain in your head, but you can still treat it using treatments that are not focused on your head.
Absolutely.
So you can still use medications, you can still use nerve blocks, you can still use physical therapy, because that's not in your head, is it?
No, and trying to speak to patients about pain, because it's complex from a neuroanatomy point of view, from a biological point of view. As pain physicians, I always have to put my hand up and say to patients, look, we still don't understand everything around this pain processing pathway, how it works normally and how it works in these abnormal pain states. We understand a lot and the research is still oncoming and we're getting better and better at trying to manage this the more and more research that comes through. However, our understanding on it is still limited.
So a patient comes to you and says, I've been told time and time again that this pain is in my head. I have CRPS, but it's all in my head. How do you reassure them? What do you tell them? Or is this what you've basically been talking about, what you tell patients?
So I try
to reassure them to I don't know, let them not feel so stigmatized and pointed at.
So every patient that comes into a pain clinic is believed because their pain that they're experiencing is affecting every aspect of their life. They're not going to work in some instances. They're not engaging in social function. They're starting to lose friends. The family are getting tired of hearing about their pain. They're losing their social fabric in their lives to a large degree because this pain, how long this pain is ongoing and the limitations it sets on their lives. No one would make this pain up. No one would want to be in the States. This pain is absolutely real, and patients have to understand that there's a strong validity for their pain. What they're experiencing is a real sensation.
They get stigmatized by it, so they don't go to the emergency department, they don't go and see their GP, they don't go and see their specialist because people say, well, it's all in your head. And that's completely wrong. Okay, excellent. So that's myth number one. Myth number two, Bradley, again, we hear this all the time, especially in people that have got CRPS. And the idea is that if their scans are clear, if the scans are fine, the pain is not there. The pain is exaggerated. So if nothing shows up on scans, the pain isn't real. And that's the second myth. What is the problem with relying too heavily on imaging to diagnose CRPS?
I think the problem with imaging and patients' understanding around the imaging is we've got some very good imaging tools. So we have imaging from CT scanners and MRI scanners that can look at big collections of the body and see significant pathology. We're very good at picking up diseases like cancer or tumors or blockages of big arteries and veins. However, when it comes to talking about pain, and part of the reason I was talking about earlier with the fact of our limited understanding of the research, pain happens down on the cellular level, on the microcellular level. It happens all the way from the DNA transcription of a cell to the way that the cell functions and passes on the messages of pain up into the peripheral nervous system and into the brain. And there are some imaging techniques that are coming along through research, like functional MRI scanners, which can light up and show parts of the brain are overactive or underactive. But these are really research tools, so there's nothing that's available within clinical practice to show the activation of the nervous system. And so your scan is never going to show your CRPS pain or your shingles pain because the scans haven't got enough high fidelity to pick up these nano and micromolecular changes that happen within these chronic pain states. What they are going to show is that you don't have anything serious that needs an operation right now. They're not going to tell us any clinical information about your pain state, unfortunately. And that's why when you go and see a pain doctor, we understand that the scan's not going to be anything of any significant benefit with regards to your pain. It may help us determine if we need to look at anything else in a differential diagnosis with regards to your health. But with your pain, the ultimate indicator is what the patient tells you.
It's there in front of you. Yeah, you don't need a scan to see somebody suffering. You don't need a scan to see somebody got neuropathic pain on your clinical diagnosis. You need a scan to make sure there's not a nerve compression or a tumor or cancer, like you've said, but the scans are not there to make the diagnosis. But unfortunately, a lot of our medical colleagues still rely on the scans, and when they say to a patient, well, the scan is normal, it's all in your head, I can't help you, the patient is the patient is completely lost.
Absolutely. And what the patient has to realize is that pain doesn't function in that way with a scan and pathology. Sometimes it does, but a lot of the time, I don't know about you, Nick, I see patients in my clinic with completely normal scans. And I have to say, look, the normal scan is great. It's reassuring that the scan is normal. However, your pain is still out of control and your suffering is out of control and your quality of life is very poor. And these are the things that we need to concentrate on improving and trying to manage to a certain degree.
Right. Understood. Right. So that's the second myth that we've discussed. But let's go on to the third myth, talking about timing, because many people think that CRPS will resolve over time. A lot of health professionals think, well, this is going to go away. We don't see this. We know that that's not the case. So myth number three: if you wait, it'll go away on its own. What do you have to say about just time and this problem, CRPS? And of course, that leads on to timing of diagnosis and how you make the diagnosis.
I think that's from my personal experience of CRPS, and from obviously the literature, we know that left untreated, and I think that's the big thing that we need to get across, left untreated, i.e., the patient has high levels of pain, you need to get in there and do something quickly. And whether that is education about the condition, medication, or other treatments that you can look at with certain nerve pain conditions, you need to get in there early and get the pain managed. The consequence of CRPS is that with the brain, we can learn new activities, techniques. It's also been shown through research that the brain can start to learn pain. And it may sound a bit wishy-washy. What do I mean by learn pain? And if we look at scans of patients with, going back to when I was talking about the functional MRI scanner, in CRPS, the pain starts, say, in the hand or the foot. You get changes within the spinal cord, opening up those pain pathways, and then you'll get changes within the central nervous system in the brain. What tends to happen with CRPS is these changes become more profound over time, and the brain architecture actually starts to look for these pain signals. And we can see these on the functional MRI scanners, where you can see parts of the somatosensory cortex, which is the body map of a patient with CRPS, start to become more and more lit up the longer the untreated CRPS pain goes on for. And what patients will describe to us then is the pain started in my wrist, but now it's spreading all the way up my arm, is involving my neck now. I'm starting to get the pain mirroring across in the other hand. The hand that wasn't injured, was unaffected, is now starting to become painful in the same way as my injured side of the body. And what tends to happen is you get these cross-linking of these nerve pathways in the brain, opening up these pain pathways. In my opinion, I think with CRPS, you need to get in there early and you need to start treating the pain to prevent this condition from progressing and becoming more burdensome.
I think if we see CRPS within days or even weeks, and I say this to people, GP specialists that I talk to, we can cure it. And certainly we see that if I see a patient within days, but if I see a patient within months or years, it's really hard to undo that, like you've said, that kind of structural change that occurs, that nerve plasticity. So if you wait, it'll go away on its own. So early treatment is an absolute must. And the main treatment is movement. And to get movement, you need some form of pain reduction. And that pain reduction is either medications or temporarily or changing the nervous system using a nerve block or a radiofrequency ablation or something along those lines. Of course, it's much more complex than that, isn't it?
Absolutely. But I think the key message is get in there early, institute treatment early, and there's a number of medications that we can get on board and get the limb moving. Because what can be a consequence of the untreated CRPS is significant disability lifelong for a patient.
So you've mentioned, so don't wait, get in early. The diagnosis is a clinical diagnosis, not based on scans. And the clinical diagnosis is something that you can sometimes see. There are there are
Absolutely.
those changes.
The scans are useful, like you said, sometimes to rule stuff out, but this is a clinical diagnosis that requires early treatment, early intervention, and a multidisciplinary team approach. So you'll have your pain specialist. You'll also have, it's also useful to have other specialists like a physiotherapist or an occupational therapist to help the patient start to move the limb again and retrain the brain to a large degree.
So people talk about this diagnostic criteria called the Budapest criteria. Now, we'll probably flash this on the screen during our discussion. In a couple of sentences, what is the Budapest criteria? How can people at home get a sense of whether they might have CRPS?
The Budapest criteria actually came about from a consensus document. So a lot of clinicians got together. We knew there was this clinical phenomena of CRPS, chronic regional pain syndrome. People were trying to diagnose it in different ways, and we came across together as a group of healthcare professionals and devised the Budapest criteria to try and streamline the process to a large degree and allow a more research to take place. And the Budapest criteria has evolved over this time. So there's been numerous conferences. I think the last one was Valencia, where they've refined some of the aspects of CRPS combined with the research studies that have come out since then. But essentially, it involves for clinicians to look for 4 different categories of signs and symptoms. And the signs tend to be sensory signs, and we give it some very clever names, but basically, they're what patients report as the sensations that they're experiencing. And then there's symptoms of this. So when patients report painful hands, we try and do some sensory testing of the skin. And if on light pressure that elicits pain, we know that's a symptom called allodynia. So painful stimulus from a non-painful sensation. There's some what we call vasomotor or pseudomotor, where patients say, look, I get out of the shower, my foot is all red, the right foot is red, the left foot is blue, and so there I can see color differences. And then in the clinic, you'll actually see it yourself in these patients. There may be a temperature difference as well, and that's part of the diagnostic criteria, where you can feel the one hand and the other hand feels colder or hotter, and both limbs should be at the same temperature. So, and lastly, there can actually be changes within the skin, nail beds, where the skin starts to take on this waxy appearance, or you start to lose hair on the affected limb compared to the non-affected limb.
And I suppose if you leave it long enough, you can actually get contractures, can't you?
Absolutely.
But the big thing for patients is that the pain is out of keeping with the injury normally. We've seen people that have got a little fracture or sprain of a wrist. It's just a tiny little thing. There's not even a big break. And the pain is off the chart. The pain is out of control. And of course, there's no better cause to explain the pain. That's right. There's no better cause to explain the pain. So it's not a blocked blood vessel. It's not a infection. It's not a cancer. So it's minor injury, excessive pain, all these physical changes, and nothing can explain it. Okay, let's get on to myth number 4. CRPS only affects the limb that was injured. And I think you alluded to this already a little while ago, where things kind of change and progress. But how common is it or how often do you see CRPS in patients that you treat where it's not at the site of injury?
Well, if you get onto patients early and get the pain well managed, we hope that that cortical reorganization and neural remapping in the brain doesn't occur. However, if it's not treated effectively, absolutely. I see patients say, my hand is starting to mirror the other hand. So it does absolutely happen in CRPS, where the pain will start to be in non-injured areas. And it's a complex condition, especially when it becomes into this chronic phase to then treat and deal with, unfortunately. And as you were saying, Nick, early diagnosis, early intervention, I think, is key. It's one of those conditions where in the chronic pain medicine sphere, I think you need to get in and see a specialist with this condition as soon as possible.
I see that all the time. Misdiagnosis, wrong diagnosis, patient fobbed off, and we see them 6 months down the line, a year down the line, and we've got a lot of catching up to do.
You have to unwind all of those processes, and
Correct.
it just makes a tricky condition so much harder to then manage later on down the line.
So finally, let's talk about the 5th myth. And again, I'm going to get you to answer or mention or talk about this fifth myth, but directly to patients, because again, you see this all the time. We see this all the time. Patients get told a lot of the time, there is nothing I can do by whoever is managing them. There is nothing I can do, just live with it. There is nothing to do for your pain problem, live with it. What do you tell patients?
I think that's absolutely unfair on patients, really unfair. And it's a very lazy approach to manage chronic pain,
Yeah,
whether it's CRPS or not CRPS. And you're right, Nick. I have patients come in, I've seen my healthcare professional, they've given me X diagnosis, whether it's CRPS or another chronic pain condition, and there's nothing that you can do about it. There's always something that you can do with regards to pain management, whether it is utilizing an appropriate allied healthcare team, whether it's trying some of the different medications, whether it's trying some of the more complex therapies. I don't think there's ever a patient where there is nothing that can be done.
yeah, okay.
Because as we were kind of talking about earlier, the pain is one element. It's the distress, anxiety, loss of function, and suffering that's resulting in the patient as a consequence of that pain. And even if you can't make the patient pain free, we can try and manage the condition, improve a patient's quality of life, work on their function, whether it's physical capacity, social functioning, and mental health, distress, anxiety, and try and improve a patient's quality of life. I don't think I'll ever turn around to a patient and say, there is nothing that we can do to help manage your symptoms.
That's good.
Is it tricky? Is it difficult? Absolutely. Can I do it on my own? I can't manage chronic pain on my own, Nick. Can you do it on your own?
No, it's got to be a team.
And it has to be a team effort. And there's going to be multiple things that we're going to have to do all at the same time to try and get the patient to
Yeah,
improve. But to tell someone that there's nothing further that you can do for their pain condition, I think is a bit unfair and a bit disingenuous.
I agree completely. And look, if I don't know how to manage something, then of course I come and knock on your door and we have a discussion about it and we work out a different plan of action or an alternative plan of action. I think I've got one more question to ask you. Again, what do you want patients to understand about treatment options for CRPS today? I know it's a bit of a vague question, but we've said you've got to do a little bit of physical therapy, a little bit of medications, a little bit of multidisciplinary approach. But what do you want to tell them in terms of understanding the treatment options for CRPS?
From my perspective, what I want to do for a patient is just make them aware that there are options. Because patients, like you said, will come in, they've either got a diagnosis or haven't got a diagnosis, and they've been told, I have to live with this. And there's things that we can do to try and manage it. And I'll build it up usually into a 5-step process. So there's all stuff that we can do within our own lifestyle, whether it's looking at diet, exercise, working on some of the basic factors, for instance, smoking, because we know smoking can increase neuropathic pain conditions, getting any of their other medical comorbidities associated with their pain, like their diabetes, under control, getting them involved in seeing a dietitian to work on some of these aspects of weight management. Because if you're um, overly obese, again, your body can be in this pro-inflammatory state. It can worsen it. So trying to get some of the basics under control, I think, is vital, because that's going to help you achieve the long-term outcomes that you're looking for. Looking at different medication profiles, so engaging with some different medications, whether it's some analgesic medications to try and manage the pain. In, say, CRPS, do we put you on a course of steroids? Look at vitamin C, look at some alternative nerve painkillers, look at some alternative medications that may be appropriate if you have side effects to some of the common medications.
So there's a lot you can do with medications, because a lot of patients come to us and they said, I've tried number one, I've tried number two, and they've said, that's it.
But, there's about 10 different medications that you can use in this condition. And with every medication, there's always going to be a double-edged sword. And, the medications that we have at the moment to treat pain, I have to put a disclaimer out there, aren't fantastic. When we look through research papers, we normally give medications something called a number needed to treat. And that number needed to treat is how many patients I'd have to treat before I have a patient who comes into my clinic and says to me, Brad, this gave me a 50% reduction in my pain. And for a lot of the medications that we use in pain, don't forget that patients will have a different receptor profile. They'll handle the drugs differently in their liver. And so as we look different on the outside, we look different on the inside of our bodies as well. And our bodies are going to handle some of these medications differently. And so from my perspective, a good analgesic is something that helps give some pain relief and doesn't give side effects to the patient. And so for the drugs that we have on the market at this point in time, the number needed to treat varies quite greatly, with some of the traditional medications anywhere from about 1 in 5 to about 1 in 10 for a lot of the medications. That means I need to try this medication on either 5 to 10 patients before I have one that says, we're on to a winner here. So when I speak to patients about medications, I tell them, I'm going to trial you on this medication. Am I experimenting with my patients? No, I'm using the evidence-based research to say these medications would be appropriate in your pain condition. However, I know on the individual basis, I've got about a 1 in 5 to 1 in 10 chance of this being a knockout success. If it's not a knockout success, we can go and try one of the other medications that may also be appropriate and may get us that double whammy of pain control without significant side effects.
Right.
So
Got
it's
it.
really a bit of trial and error with some of these medications and the patient's responses.
And expertise mixed in a little bit with that, and experience mixed in a little bit with that.
It's absolutely right, Nick. What do you usually say to the patients?
Same thing. I mean, we've got to get the pain controlled, however we do that, so that we can get you moving again, so that we can focus on your mental health, so that we can get you back on track, because of course people are off track. So, and how do you get the pain controlled? However, whatever works. And it's normally a combination of medications, of which there are many, nerve blocks, nerve radio frequencies, so focusing on that part of the nervous system to wind it all back down, and even using some advanced therapies like neurostimulators, whether they be peripheral or central neurostimulators, so targeted electrical therapy on the nerves that are malfunctioning. And of course, in some instances, you can even use targeted drug delivery. So it's a big area, and that's why we are a team. That's why we work as a team, because there is no one person, there is no one medication, there is no one anything that's going to work on CRPS. It's got to be a combination, and don't give up. Finally, I'd like you to say you have an audience in front of you. What do you say? What is the one thing you would say to people out there with CRPS that might be feeling helpless, unheard of, lost?
If you're suffering from this condition, I suppose there's two things that I want to say to a patient. Number one, absolutely your pain is real. This is not all an imagined fictitious condition. This is a real condition. You've had some real signs and symptoms that people will be able to see, which is on one extent unlucky, but on the other extent, it's something that we can diagnose and we can have some objective evidence for, whereas other nerve pain conditions, it's not always like that. And number two, there's people out there that can help you. There are physicians out there who are specialized in managing chronic pain conditions like CRPS that will be able to give you these options. Seek help and seek it early. And let's see if we can reverse some of these learned nerve pathways and restore some function.
Excellent. Well, thanks for that, Brad. I think we'll wrap it up there. Clearly, this is the opinion of two medical specialists. This is not medical advice. If you have questions, ask questions. We'll have the ability to share comments down below if this is a video that you're watching. And what we'll also do is share some resources down below for you to click on and have a read about CRPS, because power or knowledge is power. And if you've got power and understanding, you've got the ability to get back on track and get the right help. How was that?
Thank you so much, Nick. I think that was great, and I hope the audience appreciate that, and I look forward to joining you again in the future.